Good. Okay. We'll start first by the examination of the abdomen by the plain X-rays, and as you all know that the plain film of the abdomen has a great role in the diagnosis of different problems, including the detection of radiopaque calculi, the detection of calcium, the detection of abnormal normal gas patterns, the diagnosis of foreign bodies, also intraperitoneal fluids, as well as pneumoperitoneum, and gives some idea about the enlargement of the abdominal organs, as well as the bony abnormalities of the spine and the pelvis. And here is an example of the radiopaque calculi, including the renal stones, and this is a large, what we call a staghorn calculus, and this is another calculus in the left kidney. And here we can see two radiopaque calculi in the region of the gallbladder outside the shadow of the kidney. And this is an example of multiple calcific areas in the kidney, diagnostic of nephrocalcinosis. And here we can see a calcified lesion in the pelvis of a female patient representing calcified fibroid. Then calcification along the course of the pancreas are usually diagnostic of chronic pancreatitis, as calcification of the gallbladder wall is diagnostic of porcelain gallbladder, which is a well-known precancerous condition. And from the plain X-ray, you can also diagnose the presence of small and large bowel obstruction by the detection of gas-filled bowel loops. And in the erect position, you can see multiple air fluid levels. Then you reach the diagnosis of intestinal obstruction. And here you can see in this erect film multiple air fluid levels suggestive of intestinal obstruction. And the CT scan of the same case showed the presence of a colonic stricture or malignant lesion, which is the cause of this obstruction. Also, normally you can see in the plain abdomen some radiolucent line, or what we call the flank strip, which is made of fat. And in cases you have intraperitoneal fluids, this fat will not be seen, as you can see in this patient with obliteration of the flank strip due to the presence of ascites. The detection of intraperitoneal air, which is known as pneumoperitoneum, can be reached from the chest X-ray in the erect position, and you can see air under the diaphragmatic copula. But also you can reach this from the plain abdomen by the fact that whenever you are able to see the wall of the bowel, then this indicates that you have air inside the bowel and air outside the bowel. Then you can diagnose this, and this sign is known as the regular sign. Also, from the plain film, you can suspect organomegaly, such as in this pediatric patient with a huge spleen, is well seen in this plain film. And multiple foreign bodies can be detected by the plain film, as this one in the ileocecal region, and this foreign body in the rectum, and this is the original foreign body itself. And too many tablets are seen in the radiopaque, or iron tablets seen in the stomach. And here you can see multiple radiopaque foreign bodies along the course of the intestine. Then we came to the assessment of the gastrointestinal tract using the barium studies. And barium, as you all know, is a good contrast medium to diagnose a roadmap of the gastrointestinal tract, and it can show exactly the site of the lesion and can predict also the nature of this lesion. And barium was previously provided as a powder, and you can dissolve this powder in water and then give it to the patient. But nowadays, this barium preparation are provided in a ready-made preparations like this, which are directly administered to the patient. And sometimes we cannot use barium in these conditions. Whenever we are suspecting perforation of the bowel, or suspecting intestinal obstruction, or after surgery, whenever you are suspecting anastomotic leaks, then we replace the barium by the water-soluble contrast material, which is known as gastrographene. And this gastrographene is safe whenever it is leaked from this perforation, for example, into the peritoneal cavity. It will be absorbed rapidly. Then, in order to examine the gastrointestinal tract by barium, we have this particular examination, which is known as the double contrast study. By double contrast, we mean we give the patient barium and we give also air. And this air can be delivered into the stomach through effervescence and through the colon through the enema itself. Then we have four main regions in the gastrointestinal tract. The first one is known as the filling defect, the second one is known as ulcer, the third is the diverticulum, and the fourth is the stricture. Then by the filling defect, we mean that we have a lesion inside the lumen of a part of the gastrointestinal tract, and this lesion prevents barium from accumulation in this area. Then we call this an intraluminal filling defect. Also, some extraluminal filling defects can impress or compress the bowel from outside, producing this extrinsic compression. Then by stricture, we mean we have an area of narrowing in the bowel lumen. And this narrowing may be smooth, giving this very characteristic configuration, which is known as the rat tail configuration, which usually means that you are dealing with a benign lesion. But whenever you see this characteristic lesion, which is known also as the apple core configuration, you see a narrowed part of the lumen, and you see proximal shouldering and distal shouldering, then you know that you are dealing with a malignant lesion. Then by a diverticulum, we mean that there is a circular outpouching of the bowel lumen, which is filled by barium. And you can see this is the duodenum, and this is the classic appearance of a diverticulum. Also, this is a barium meal, and you can see a diverticulum arising from the third part of the duodenum. The ulcer is an area of damaged mucosa where barium can accumulate. And if you look to the ulcer from the front, and you can see a persistent collection of barium like this one. And if you look to the ulcer from the side, then you see a protrusion beyond the contour of the bowel. Then we'll start to see these four lesions in the different parts of the bowel, starting by the esophagus, and the esophagus is examined by what's known as barium swallow. And for obtaining this barium swallow, we usually give the patient a barium paste. And this barium paste is semi-solid in configuration, and it is swallowed by the patient, and we look to the flow of barium through the esophagus under screen control. And usually we should have an image for the esophagus whenever it is filled with barium, and another image for the esophagus whenever it is not filled with barium. This for filling defects and the configurational anomalies, and this for the detection of mucosal lesions. And concerning the four main items we have discussed before, the stricture, filling defect, ulcer, and diverticulum. Then we have in the esophagus, we have four types of strictures. The first one is the corrosive stricture, the peptic stricture, the stricture due to achalasia, and the stricture due to malignancy. And this is an example of peptic stricture, which is usually of benign nature, showing the classic rat tail configuration, and is located mainly in the distal part of the esophagus. This stricture is secondary to gastroesophageal reflux and peptic esophagitis, which will end by narrowing of the lumen, and you have this characteristic site and the appearance of the peptic stricture. While the corrosive stricture is usually seen in children and mentally defective patients, and this stricture is located high up in the esophagus. It is very long and showing the classic benign appearance of the strictures. And this is another case of corrosive stricture, and you can see the long stricture and the smooth outline of the narrowed segment. And this is the classic appearance of achalasia of the cardia, where you can see a benign area of narrowing in the distal part of the esophagus with proximal marked esophageal dilatation. And this is also a case of achalasia of the cardia with narrowing of the distal part of the esophagus due to neuromuscular incoordination. Then the malignant stricture will show the classic apple core configuration, as you can see here. And this is a malignant lesion in the mid part of the esophagus with mild proximal dilatation and the characteristic proximal and the distal shouldering. And this is another case of a malignant esophageal stricture with proximal and distal shouldering. You see the irregular narrowing of the esophageal lumen. And this is the third example for malignant esophageal stricture involving the mid part of the esophagus. Then we came to the filling defects inside the esophagus, and these filling defects will represent benign and malignant lesions and also the esophageal varices. And actually, whenever you look to the filling defect in the esophagus, you cannot reach the diagnosis without the help of an endoscope. And this, because of the marked irregularity and the destruction of the esophageal outline, is considered the malignant one. Then if you look to the esophagus and you see multiple worm-like filling defects representing the dilated portosystemic collaterals in the wall of the esophagus secondary to portal hypertension, then you know that you are dealing with esophageal varices. And this is another example of an esophageal varices showing the classic worm-like filling defects in the esophagus. Then you came to the diverticuli. In the esophagus, we have three types of diverticuli. The mid-esophageal diverticulum, like this very small one, and the Zinker diverticulum, which is usually located in the upper part of the esophagus in the cervical region. And this diverticulum classically is presented posterior to the esophageal lumen, usually in line of the food of the swallow. Then this is what we call epiphrenic diverticulum, which is located immediately above the diaphragm. And this is frequently mistaken with hiatus hernia, but the fact that you can see that the gastroesophageal junction is located below the diaphragm, you know that this is not a hiatus hernia, but an epiphrenic diverticulum. Then we came to the stomach, and we examined the stomach by the barium meal. We give the patient barium fluid, and we radiograph the patient in different positions, as you can see. Then this technique aiming at filling the different parts of the stomach, once by barium and once by air. Then here you can see the fundus is filled with barium, but here is filled with air, and the opposite is seen here, and you see the pylorus and the distal part of the stomach containing barium, while here you can see it with air. Barium filling the part of the stomach for configurational abnormalities, and air for mucosal changes. Then in order to test for the gastroesophageal reflux, you can put the patient on his right side and ask the patient to swallow his saliva only. By this time, you can see that the gastroesophageal junction is open, and the barium is coming from the stomach into the lower part of the esophagus. And this is a classic appearance of gastroesophageal reflux, showing that the barium is coming from the stomach into the most of the esophageal lumen. Hiatus hernia is also diagnosed by the presence of a part of the stomach above the diaphragm. And here you can see this is the gastroesophageal junction, and this is part of the stomach, and this is the diaphragm. And you can see a major part of the stomach is above the diaphragm. Also, this is another case of hiatus hernia, and you can see this is a good part of the stomach which is located above the diaphragm. And this is also an example of hiatus hernia with gastroesophageal reflux, showing part of the stomach in the lower part of the thoracic cavity. Then concerning the strictures in the stomach, we have two main types. The first one is due to infantile hypertrophic pyloric stenosis, and the second one is due to serous carcinoma of the stomach. And this is the classic appearance of hypertrophic pyloric stenosis. And you can see hypertrophy of the pyloric muscles, markedly reducing the lumen of the stomach. And this is reflected on the barium study by a narrow track corresponding to the pyloric canal and the proximal dilatation of the stomach. This particular disease can be easily diagnosed by ultrasound, as you can see, and you can measure the thickness of the hypertrophied muscle as well as the length of the pyloric canal. And this is another example of hypertrophic pyloric stenosis with narrowing of the pylorus, distension of the stomach, and this is the gross specimen of the same case. The narrowing of the stomach may also occur secondary to infiltrative carcinoma of the stomach, which is known as a serous carcinoma, and you can see the appearance of the carcinoma reducing the gastric lumen. And here you can see a marked reduction of the gastric lumen secondary to carcinoma. And you can compare the serous carcinoma of the stomach by the normal stomach, which is distensible, having a good configuration, compared to this, which is markedly, where the lumen is markedly reduced, and you can see irregularity of the wall of the stomach. Then you came to the filling defects, and they are usually due to benign or malignant lesions and also due to foreign bodies, which are known as gastric bezoars. And this is an example of a gastric bezoar where you can see a foreign body in the stomach. Can you predict the nature of this foreign body? Yes. Super. Any other possibilities? Glass. Okay, this is the foreign body. And you have two of these foreign body inside the stomach. This one in the fundus and this one in the pyloric canal. Okay. And here you can see an example of this gastric bezoar, which is made of non-digestible fibers, a lot of fibers which occupy most of the stomach, and these fibers cannot be evacuated unless without surgery. Then the filling defects corresponding to benign and malignant neoplasms are not mobile. And you can see this filling defect in the pyloric canal, which may represent a benign tumor like leiomyoma, for example, or a malignant tumor like carcinoma and leiomyosarcoma. And you always need the help of endoscope in order to reach the final diagnosis. This is a case of filling defect in the gastric body along the greater curve of the stomach, which is suggestive of carcinoma because of the marked irregularity of the wall of the filling defect. Then you came to the gastric ulcers, and we have two types, the benign ulcer and the malignant ulcer. And there are a lot of differences between both. The benign ulcer, you see an area of damaged mucosa, and you can see that the mucosal folds reach the edge of the ulcer. This is a character of a benign lesion. While in a malignant lesion, you can see that the mucosa stops away from the edge of the ulcer, as you can see in this gross specimen, with the malignant ulcer infiltrating the adjacent area of the stomach, and the mucosal folds are stopping away from the edge of the ulcer. Then the criteria for malignant ulcer in the stomach, and that the ulcer is usually located in the lesser curve. It is usually larger than 2 centimeters in diameter, and the mucosa stops away from the edge of the ulcer itself. Then you came to the duodenum, and we have in the duodenum, this is the duodenal loop, which is the most important part to be assessed by barium, and the commonest lesion affecting the duodenal bulb is the ulcer. And the ulcers are also acute or chronic. The acute ulcer is just an area of mucosal irregularity containing persistent amount of barium with the mucosal folds reaching the edge of the ulcer. And the chronic ulcer will appear like this trifoil configuration due to cicatrization and the fibrosis of the duodenal cap, giving the typical configuration of this leaf. Then this is a chronic duodenal ulcer compared with the normal duodenal cap, and you can see that the classic trifoil configuration of the duodenal bulb. Then duodenal diverticuli are usually located in the second part of the duodenum, and because of their intimate relation to the common bile duct orifice, there may be some biliary problems sometimes. This is a good example of a duodenal diverticulum. Then we came to the small intestine, and we examined the small intestine by what is known as barium meal follow-through. We give the patient barium fluid, and we radiograph the abdomen at intervals, usually at 30 minutes interval, in order to see the flow of barium along the different parts of the small bowel. And this is a series of barium meal follow-through, where you can see the stomach and the duodenum, then you see the jejunum, then you see most of the jejunum and ileal loops, and the examination is not finished unless you see the colon and you look at the terminal ileum or the ileocecal junction. Then the small intestinal lesions that can produce filling defects, ulcers, and strictures in the same time. This is the most common disease, which is known as the Crohn's disease. The Crohn's disease is usually located in the terminal ileum, and this is the normal appearance of the terminal ileum, and this is the terminal ileum which is involved by Crohn's disease, where you can see marked lumen reduction and irregularity of the wall. This is a characteristic appearance of Crohn's disease. This is also another example which is typical of Crohn's disease, and you can see the terminal ileum is markedly reduced in caliber with serrated outline due to micro ulcerations. Then Crohn's disease may also produce filling defects in the terminal ileum, and that's because the hypertrophy of the normal mucosa in between the ulcerated mucosa, giving this configuration which is known as the copelestone appearance. And Crohn's disease in the intestine is also characterized by what's known as the skip lesions. Skip lesions meaning that you have an area of diseased bowel, then a healthy area, then another area of diseased bowel. This is what is known as the skip lesions. Small intestinal diverticulae are not common compared to the duodenal diverticulae, but sometimes you can see multiple diverticular outpouching, as you can see in this case. Then you come to the barium enema, and the barium enema is obtained by injection of barium through the rectum until we opacify the whole of the colon. And sometimes we inject air with barium in order to have this particular study, which is known as double contrast barium enema. And this is a good example of a normal double contrast barium enema showing most of the colonic segments. And the colonic lesions will include the same items: filling defects, ulcers, diverticulae, and the strictures. And here is a good example of diverticular disease of the colon, where you can see multiple diverticular outpouching protruding from the colonic lumen. And this is also another example of diverticular disease with multiple diverticulae. You know that diverticular disease is usually or commonly affecting the distal part of the colon. Then ulcers in the colon may be the sequelae of ulcerative colitis very commonly, and less commonly due to Crohn's disease. And in order to diagnose ulcerative colitis, you look to the colon. This is the normal colon with classic haustral pattern. And in the ulcerative colitis, the haustral pattern is totally lost, and you get the marked luminal narrowing, as you can see in this case. And this is another case of ulcerative colitis with loss of the hostrations of the colon and marked reduction of the lumen of the colon as well. And if you look carefully to the colon in early stages of ulcerative colitis, you can see micro ulcerations, which are presented here by areas filled with barium throughout the examined part of the colon. This is an early stage of ulcerative colitis. And this is the normal colon once more, and this is the colon which is affected by ulcerative colitis. Then one of the most common complications of ulcerative colitis is the development of carcinoma on top of a pre-existing ulcerative colitis. And you see, this is the colon which is affected by ulcerative colitis, and this area shows the classic apple core configuration, which is typical of malignancy. Then polyps of the colon or filling defects in the colon may result from benign polyps, malignant polyps, and in some cases is due to intussusception. Then in order to differentiate between benign and malignant polyps, the benign polyps usually have a pedicle and the smooth outline as well. And you can see multiple polyps in the colon showing the benign characters, pedunculated appearance with a smooth surface. But the malignant polyps are usually sessile with no pedicle and irregular outline of the polyp itself. Then this is an example of a well-known disease in the colon, which is known as familial bulbosis, where you can see too many polypi in the colon, and you all know that this disease carries 100% risk of malignancy. And this is a good example of intussusception, where you can see this filling defect in the transverse colon and corresponding to the intussusception. And the intussusception can be easily diagnosed using ultrasound. And you can see here the classic Worley configuration or target sign where the intussusception is present, and this is the surgical image. Then you came to the strictures in the colon. We have the malignant strictures, which are very common compared to the benign strictures, and we got a stricture due to Hirschsprung disease, which is the aganglionic segment in the colon. Then whenever you see this apple core configuration, which is with the proximal and distal shouldering, you know that you are dealing with a malignant lesion. And this is another case of malignant lesion in the transverse colon, showing the typical configuration. And also here you can see this malignant stricture with apple core configuration, proximal shouldering, and distal shouldering. In cases of Hirschsprung disease, you see an area of aganglionosis in the colon, which is usually narrowed with proximal dilatation of the colonic segment. And this is a classic example. By plain X-ray, you can see huge distension of the colon by fecal matter. But after injection of barium, you can see that there is a segment here which is relatively narrow compared this huge dilated part of the colon. And this is the end of my talk, and I thank you very much.